Good morning, sir.
Yes, now we can hear you.
Sir, am I audible?
Yes, please share your screen.
Yeah, just a second.
Okay, we can start.
Yes, sir. Good morning, everyone. I'll be presenting a case. So the demographics are a 67-year-old male patient, a painter by occupation, resident of Alwar, Rajasthan, came with the chief complaint of difficulty in swallowing since 4 months. History of presenting illness. Patient was apparently normal 4 months back when he noticed difficulty in swallowing solid food with a sensation of food being stuck in the upper chest, which was insidious in onset, initially requiring water along with solid food to facilitate the act of swallowing. Followed by that, gradually, the difficulty in swallowing food has progressed over 2 months, wherein now he can consume only liquid diet. He gives a history of 15 kgs of unintentional weight loss over the past 2 months, which is associated with history of loss of appetite. He gives no history of dinophagia, halitosis, neck swelling, gurgling sound while swallowing, difficulty in initiating the swallowing, or dysarthria or nasal regurgitation. There's no history of associated chest pain or postural modification for facilitation of food and relation of temperature to the food. There's no previous history of corrosive intake, no history of symptoms suggestive of long-standing regurgitation, no history of hematemesis or melena, or no history of cough with expectoration or recurrent URTI, no history of coughing or choking after swallowing, no history of hoarseness of voice or stridor, no history of backache, no history of abdominal distension, jaundice, hemoptysis, bony pain, back pain, blackouts, or seizures. Past history, there's no history of tuberculosis, stroke, diabetes mellitus, hypertension, asthma, or COPD. There's no there's no significant family history. His personal history, he consumes mixed diet, normal bowel and bladder habits, sleep is undisturbed. He gives history of BD smoking since past 40 years, approximately one bundle, that is 25 BDs per day. And he is a chronic alcoholic with consumption of approximately 180 ml of country liquor since past 40 years. Summary, a 67-year-old male with no comorbidities, chronic BD smoker and alcoholic, comes with complaints of progressive dysphagia, which is initially for solids, later progressed to liquids since 4 months, with associated significant loss of weight and appetite. So, depending upon the history, by provisional diagnosis is malignant dysphagia secondary to probably carcinoma esophagus or carcinoma G junction.
Go back to your first slide. So we have discussed the clinical part of dysphagia, I think, in last few classes in great detail. So I would not go too much into this so that we can go on to the management. First slide before this. As I have said many times earlier, for me, it is okay if you say dysphagia for 4 months, but still, especially in DNB exam or even in MCH exam, you may have an external examiner who insists that history should be presented in patient's words and terms. So it is much better, much safer to say difficulty in swallowing.
Yes, sir.
Next. So food being stuck in the upper chest, and you are making a diagnosis of CAGE junction.
Yes, sir. Sir, actually, the relation, I cannot, the relation of food being stuck in the upper chest, sir, I cannot say that it is a esophageal carcinoma only, because sometimes patients will give complaints of, the level of obstruction can be lower, and patient might give a complaint of food being stuck in the upper chest because it has a very low sensitivity. Approximately 30% patients only will be able to actually localize the site. So I have kept it as a second.
No, that is okay. But here he is able to localize. So once the patient is able to localize, what is its relationship to the site of the lesion? He says food is getting stuck in the upper chest.
Yes,
What
sir.
does it mean? So it means if the food is getting stuck in the upper chest, the obstruction can still be below that. But suppose
Yes,
he
sir.
was saying food is getting stuck at the lower chest, then
Yes, sir.
obstruction cannot be in the upper chest.
Yes, sir. Yes, sir.
That is the importance. So food
Yes, sir.
getting stuck in the upper chest means that lesion can be anywhere either at that side or
Yes,
anywhere below that, but it
yes,
cannot be above that. If you have a
yes, sir.
cervical esophagus growth, the patient cannot complain that food is getting stuck in the chest or in the lower part of the chest. That
Yes,
is
sir.
the importance. Next.
Yes,
If he says 15 kg, he would know what was his weight earlier and what is his weight now. You should mention that because the definition of weight loss is usually percent of the basal weight. So either the patient says significant weight loss. If he knows exactly, then he would know the pre and post weight also. So that should be mentioned. Okay.
yes, sir.
Similarly, odynophagia, halitosis, dysarthria. I suggest that it is much safer. If you say no pain during swallowing, everybody will accept it. If you say odynophagia, one odd examiner will say, did the patient tell you I have odynophagia? Then you will say,
No.
no, no, sir, he said I have no pain. And then, okay.
Yes, sir.
Again, you have to differentiate between odynophagia, which is pain during swallowing, or chest pain, which may be there in some motility disorders like esophageal spasm, diffuse esophageal spasm, versus a persistent moderate to severe backache, which is because of the local infiltration of the tumor. That pain suggests advanced disease and probably unresectable disease, not pain during swallowing, not this pain of
Chest pain.
esophageal spasm,
Yeah,
which is
yeah,
spasmodic, which
yeah.
comes on and off. So you
Yes.
have to be clear in describing the pain. Next, why recurrent URTI?
Sir, like because the patient is having dysphagia, sir. So a patient might aspirate and patient might develop, or if there is an associated GERD
What does
also,
aspiration cause?
it will cause lower respiratory tract
So
infections.
why URTI?
Um, if there is a reflux, it can cause upper respiratory tract infection.
Why would a mechanical obstruction cause reflux? Recurrent URTI may be present in patients with severe GERD. In
Yes,
fact, some patients may present to ENT with recurrent sinusitis because of reflux of the acidic contents so high that it goes into the sinuses, nasal reflux. Or they can even present to a pulmonary department with history of bronchospasm, especially children.
yes,
They may not tell that there is retrosternal pain. They will have just respiratory distress. So in mechanical dysphagia, it is recurrent lower respiratory tract infection, recurrent chest infection. And
yes,
the last sentence, I'm sure you are trying to tell us about metastatic history. Again, I have said earlier, jaundice is not a common presentation of liver metastasis.
yes, sir. Yes, sir.
So you should not mention jaundice as metastatic history. Similarly, hemoptysis is not a common presentation of pulmonary. Pulmonary metastases are usually silent, detected on investigations, or they may cause dry, irritating cough if they are irritating, if they are close to a major bronchus. Hemoptysis comes much later. Then you can have features of pleural effusion, malignant pleural effusion, which is dyspnea on exertion,
Dyspnea and
mild
exertion.
to
Yes,
moderate, dull chest pain, which is because of malignant pleural effusion. And
yes,
then bone pain, again, you have to say, and that persistent localized bone pain, or especially in elderly patients, spontaneous fractures which occur on trivial trauma. Intracranial metastasis, the first symptom is recent onset, moderate to severe persistent headache. Then nausea, vomiting because of raised intracranial tension, and blackout and seizures are much later. Okay.
yes, sir.
Next. Okay. Next. Yeah. Okay. Fine. Go on. Yeah, so that would be the explanation, that the site of sticking of food does not indicate the between the two, which is more likely, CA esophagus and CA GE junction.
Yes, sir.
Or let me ask it the other way. What symptom could have been there which could have differentiated between CA esophagus and CA GE junction?
Sir, there could be an associated reflux in G junction tumors.
Maybe, yeah, because
G,
of
like
the
long-standing GERD, then conversion to Barrett's esophagus, and then G junction tumors.
so previous history to suggest gastroesophageal reflux disease, long-standing reflux.
Yes, sir.
Second is that bleeding is more common. GI bleed in the form of melena, not hematemesis usually. It's more common in GE junction. So if a patient with dysphagia has bleed or history of melena, then it is more likely to be GE junction rather than C esophagus. Esophageal tumors bleed less as compared to GE junction bleeds.
Yes, sir.
Rajendra, any comments on the history?
No, sir. You have dealt with it in detail.
Yeah, I thought we'll quickly go on to the management. Yeah. Carry on, Niranjan.
Yes, sir. So, general physical examination. Patient is alert, conscious, cooperative, and well oriented to time, place, and person, and is well hydrated. He's averagely built and poorly nourished. He's lying comfortably in the bed. His ECOG performance status is 1. BMI is 16.93 kilograms per meter square. He's afebrile currently with a heart rate of 78 beats per minute and blood pressure of 128 by 76 millimeters of mercury. SpO2 is 98% on room air and respiratory rate is 15 cycles per minute with a breath holding time of 30 seconds.
Anything else on general physical examination, which actually you have noticed while you were taking history, but you should mention it here? It is the voice, the hoarseness. So although you asked that there is no history of hoarseness, but patient may not have noticed, but you would have noticed. So here it is important to say that his voice is normal. There is no hoarseness of voice.
Yes, sir.
Yes, carry on.
Yes, sir. There's no pallor, icterus, or pedal edema. There's no bilateral supraclavicular lymph nodes, neck nodes, or generalized lymphadenopathy.
In CA esophagus, which nodes are important?
Sir, cervical lymph nodes are important.
So that should come first.
Yes, sir.
If it is GE junction, then supraclavicular, but in CA esophagus, all cervical nodes and bilateral cervical nodes are important. So they should come first.
Yes, sir.
You should also mention no Horner syndrome.
Yes, sir.
No, what is Horner syndrome?
So Horner syndrome is seen in cases where there is cervical T1 cervical chain involvement.
Which
Yeah, tell me what are the components?
Presents as drooping of eyelid. Which presents as
Ptosis, meiosis, and anhidrosis.
anhidrosis. Yes, sir.
it is because of involvement of what?
Sympathetic chain involvement.
Yes, sympathetic chain.
Yes, sir.
Yeah, carry on.
So, because bronchogenic carcinoma can cause dysphagia, and smokers usually get field changes in the entire respiratory and esophageal complex.
Yes,
so they
yes,
can develop bronchogenic carcinomas, and that can present as dysphagia.
Yes, sir.
Either because of lymph nodes or direct infiltration of the cervical esophagus.
Yes, sir.
Yes, carry on.
Oral cavity examination. There's adequate mouth opening with poor dental hygiene and nicotine stained teeth are present. There's no halitosis or mucosal lesions which are seen.
Rather than saying mucosal lesions, say no leukoplegia, no
erythroplakia and leukoplakia,
Erythroplakia, no ulcer, no
ulcers of
growth.
oral
So that is
candidiasis.
what you are looking for. As Dr. Desai mentioned, heavy chronic smokers have a field change in the entire upper aerodigestive tract.
Yes, sir.
And these patients are very likely or more likely than our general population to have multiple either synchronous or metachronous tumors in the entire aerodigestive tract. In fact, some groups, when they diagnose any of these tumors, do what is known as a pan-endoscopy. Uh,
Yes, sir.
Laryngoscopy, pharyngoscopy, and esophago or upper GI endoscopy to look for any synchronous lesions and tracheobronchoscopy. Yeah.
What is oral submucous fibrosis?
So, oral submucosal fibrosis is a condition seen in patients with chronic nicotine or tobacco usage, in which the temporomandibular joint undergoes fibrosis, um, and it presents as inadequate mouth opening or trismus, um, and it is a pre-malignant condition as well.
It is fibrosis of the submucosal region of the oral cavity. And because of submucosal fibrosis, there is restriction of movement of the temporomandibular joint, not
Yes.
fibrosis of the temporomandibular joint.
Yes, sir.
Yes, please carry on.
Abdominal examination. On inspection, abdomen is flat, umbilicus is central, midline and inverted. All quadrants move equally with respiration. No visible lump, scar, sinuses, engorged veins, pulsations, peristalsis, or cuff impulse. Bilateral renal angles, no fullness is noted. Hernial orifices are intact. On palpation, all inspectory findings are confirmed. No local rise of temperature or tenderness noted. No organomegaly, no palpable lump. Hernial orifices examination is normal. Bilateral renal angle is non-tender. Percussion, no free fluid. Liver dullness starts in the fifth intercostal space with liver span of 13 centimeters. Rest of the abdomen is tympanic. Auscultation, normal bowel sounds are heard. Digital rectal examination, sphincter tone is normal. There are no external abnormalities noticed. Normal fecal stool staining is present. And there are no nodules which are felt.
The DRE findings, in what sequence do you observe them?
So first, I look for any tags.
So first comes the external abnormalities.
Yes, yes, sir.
Second is sphincter tone. As soon as you put your finger, you feel the sphincter tone. Third is the nodule.
Yes,
Fourth
sir.
is the fecal staining. So they should
Yes,
be presented in the same sequence.
yes,
And
sir.
yes, it is all right. You say normal fecal stool staining, but it is better to mention no melena.
No melena, yes, sir.
Okay?
Yes, sir. Respiratory system inspection. Trachea is central in position. Bilateral chest movement is present. No engorged or dilated veins noted over the chest. Palpation. Trachea is central in position. Bilateral chest movements are equal, and normal tactile vocal fremitus is present. Percussion. Resonant note is present in the bilateral lung fields. Auscultation. Bilateral air entry is equal with normal vesicular breath sounds heard. No decreased breath sounds or added sounds were heard.
Yeah, good
Other
that
system.
you describe the chest in detail, but make sure that before you mention anything, you know how to do it. You know how to elicit vocal fremitus?
Sir,
Don't mention anything which you don't know, which you haven't done.
yes, sir.
So
What is post-cricoid crepitus?
So if I remember correctly, vocal fremitus is that you place your hand like this on the chest wall, ask the patient to speak, and then the conducted
Compare.
sound which comes and hits your finger. But check with your medical colleagues.
Yes.
I'm not 100% sure. So again, I would say if you don't know something, if you haven't done something, better not to mention it, because if you mention and then you accept that you haven't done it, that gives you more negative points.
Yes, yes, sir.
What is post-cricoid crepitus and where do you elicit it? You press the wash box posteriorly and move it from side to side. If you hear a grating sound, if you have a feeling of a grating sensation, then that means there is positive post-cricoid crepitus. It means there is no hypopharyngeal growth, which is expanding the hypopharynx and preventing the thyroid cartilage from touching the posterior vertebra.
Yes.
All the students who are attending, please feel free to ask any question. You can put it on the chat, or you can just raise your hand and we will interrupt and allow you to ask questions. And any faculty colleagues, please feel free to ask anything from Niranjan or make any comment. Yes, please carry on.
Other systemic examination is essentially normal. So my summary is a 67-year-old male with no comorbidities, chronic smoker and alcoholic with ECOG performance status of 1, comes with complaints of short duration progressive dysphagia, initially for solids, later progressed to liquids, that is grade 4, since 4 months associated with significant loss of weight, with low BMI and poor dental hygiene, with unremarkable oral, neck, chest and abdominal examination.
Just
So my
for benefit of other students, just tell us which grading you have followed for dysphagia and what are these grades?
So I have followed uh, Takita grading, sir. So grade 1 is dysphagia for solid food. Grade
Which
2,
solid food?
um, sir, solid.
It is usually meat. So if your patient is pure vegetarian, you may not be able to elicit grade 1 dysphagia. If a patient is taking pure vegetarian diet, which he is chewing well, you may not be able to elicit grade 1 dysphagia. Okay. Next.
So grade 2 is tolerating solids with liquids to facilitate the act of deglutition. And grade 3 is tolerance only of semi-solid foods. Grade 4 is tolerating liquids only. Grade 5 is able to like only saliva, and grade 6 is patient is not able to swallow saliva also.
Okay, so he comes to you. What will you do now?
Sir, I will like to investigate the patient uh, first to confirm my diagnosis. I'll do a set of investigations, A, to assess the general condition further of the patient biochemically, and B, to make my diagnosis.
Okay, let's see.
So blood investigations which I had run on him. So his HB is 10.2, TLC is 7,800.
You don't have to read everything.
So,
Just give your
so
interpretation.
my interpretation is the blood investigations show anemia along with hypoalbuminemia.
Okay. So what grade of malnutrition you will put him as? Subjectively?
Sir, mild malnutrition.
Mild or moderate. He is
Mild.
anemic. He is hypoalbuminemic, but albumin is above 3.
Yes.
If I remember correctly, he did not have any pedal edema, but he has
No,
lost
sir.
15 kg.
Yes, sir.
15 kg over 2 months is a significant weight loss.
Yes, sir.
So that becomes very important. So I would probably place him as moderate malnutrition. Okay.
Yes.
And his performance status is good.
Yes, sir.
ECOG 1, you said.
Yes, sir.
Yes. Okay. Next.
So next I will do an upper GI endoscopy. So on upper GI endoscopy, there is an ulcerative proliferative growth in the esophagus at around 30 centimeters from the incisors. So biopsy was taken in this patient, and it was suggestive of squamous cell carcinoma, which was moderately differentiated.
Suppose the biopsy was inconclusive, negative, necrotic tissue only.
Sir, I'd like to repeat the biopsy.
Anything special you will do at the repeat biopsy?
Sir, I can use indocyanine green to make the tissue yield better.
Go back to the endoscopy picture. Do you need anything to see the lesion? It is so
No,
obvious.
sir. It's a big lesion, sir.
And do you use indocyanine green to see
No, sir. No, sir. Like the tissue. The mass which we are seeing in the endoscopy. It's a
No, no. Even if a lesion was not seen, suppose it is an early lesion, do you use indocyanine green? I'm sure you are trying to say chromoendoscopy. What do you use in?
We used
What do you use to stain the esophageal mucosa? It is slipping my tongue, Rajan. Please chip in. For
Vital
chromoendoscopy.
blue, methylene blue. Vital blue or methylene blue, both can be used.
So what happens when you do chromoendoscopy? What happens to the normal mucosa and what happens to the suspicious area? Which stains?
sir, the normal mucosa stains, sir.
Yeah, it is the normal mucosa which stains. So unstained part is the abnormal part. Okay,
Yes.
and it is not ICG. Okay, so let's go back. So what do you do at repeat endoscopy if the first biopsy was negative? And this is the endoscopy picture.
Sir, we will take 6 to 8 multiple biopsies we have to take, sir, and we have to.
That you would have taken in the first instance only.
Yes, sir.
The dictum is that when you see a lesion, you take 6 to 8. 6 to 8 means that at least 2 from each quadrant. Six
Yes.
is mentioned because some quadrant may not be seen.
Yes.
The inferior most quadrant may not be seen. That is why it comes to 6.
Yes, sir.
So what else will you do? This probably you have already done at the first time. From
Sir,
where do you take the biopsy?
Sir, we take a biopsy or a deep biopsy, sir.
From where? Suppose there is a lesion. Which part of the lesion?
We'll take it from the edge, sir, because
So you
center
take it
and
at the periphery, at the edge,
yes,
where the normal is meeting the abnormal, not
yes,
from the center, because center is very likely to be necrotic.
yes, sir.
So you take it from the edge, you take multiple biopsies, you try to take at least 2 biopsies from each quadrant. That is why the total comes to about 6 to 8. And now the second time, the special maneuvers that you do are one, I presume that the standard thing has already been done, that you take deep biopsies. How do you take deep biopsies? What do you do?
Sir, we take a biopsy on a biopsy.
Yes, it's called biopsy on biopsy or a well biopsy. You try to create like a well. You keep
Yeah.
digging at the same place. Of course, an expert endoscopist has a subjective mental assessment of the thickness of the esophageal wall. So you don't go as deep that you cause a perforation, but you take deep biopsy. What else can you do? Any other equipment you can use?
Sir, we can use endoscopic ultrasound if it is available.
Endoscopic ultrasound guided fine needle
Needle
aspiration cytology or biopsy, because when you take a punch biopsy through the endoscope, you are taking a surface biopsy. On
Yes.
the other hand, when you do EUS guided needle biopsy, the needle goes into the growth. So you take a biopsy from the core of the tumor, not from
Yes.
the surface of the tumor. So these
Yes.
are some maneuvers which, if first biopsy is negative, then you do at the second. Suppose second also is negative. How old
Sir,
was this patient? Sorry, he is 40, isn't it? 45.
no, sir, there is a misprint. Actually, his age is 67, sir.
Oh, okay. Suppose he was 45, dysphagia. You do an endoscopy. You see a suspicious lesion, but mucosa looks normal. You do biopsy, negative. You do another biopsy, repeat endoscopy biopsy, again negative.
Um,
So what I'm trying to hint at, if you have a relatively young patient With normal looking mucosa, it is more like a submucosal lesion and repeated biopsies are negative. Immediately, two conditions should come to your mind. One is lymphoma, and second
Yes.
is a tuberculosis. Tuberculosis coming from outside, which is causing external compression. So a young patient, submucosal lesion, repeated biopsy is negative, and then if you do imaging, it shows circumferential mural thickening of the wall of the viscus. That is the classical picture of a lymphoma. Tuberculosis, mainly mediastinal nodes, which are
Regressing it.
infiltrating or compressing the esophagus from outside, so creating mechanical compression, but no mucosal abnormality. And in both these conditions, an EUS guided biopsy will be of much help. Okay? Yes,
Yes.
let's proceed.
Niranjan, what is cytobrush?
Don't keep quiet. If you don't know, say, I don't know, so that the
So I,
examiner can either tell you or ask you another question. If you keep
sir,
quiet, then I'm waiting. If you
sir,
don't know, say, I don't know.
I don't know, sir.
Yes. If you don't know, you get 0 out of 0. If you give a wrong answer, you get -1 out of 0. If you keep quiet, you are wasting time. You might as well
But
utilize time for the
basically,
examiner to ask a question which you know the answer. Okay?
Yes.
yeah, it's basically a capsule which contains a brush inside it under compression. It is tied to a thread and passed, and a patient is made to swallow. It goes and opens up inside the abdomen after it is digested and releases the brush. And when you pull it back, it takes a brush cytology of the entire esophagus and the G
Yes.
junction.
Yes.
So, if a biopsy is negative and there is no lumen occlusing lesion, you can give cytobrush.
This breast cytology is more of use in screening programs where you do an endoscopy as a screening, and then you take a brush. As Dr. Desai said, it takes a brush from the entire esophagus. So even if a lesion is not obvious, if there is a lesion there, you will see some abnormal cells in the cytology. And this is done in countries or in areas where there is a high incidence of esophageal cancer. Do you know any geographical region where there is a very high incidence of esophageal cancer?
Sir, in Japan and China, sir.
China. There is a part of China, I think it's mainly in the western part of China,
Yeah.
where there is a very high incidence of esophageal cancer. Okay, let's go on. Japan and Korea are mainly stomach. They have a
Stomach,
very
yes.
good screening program for stomach.
Yes, stomach, yes.
Yes. Yeah. Next.
Sir, I have
Would
got.
you have done an ultrasound of the abdomen?
Yes, sir.
Why?
Sir, ultrasound will give me a good guide if there are any metastatic lesions
Where?
in the liver.
What was the histology in this case?
Squamous cell carcinoma, sir.
Do you expect liver metastasis?
No, sir.
I don't say no, but
But I mean,
less likely.
it is less likely,
So
yes,
you
sir.
should have said if it were an adenocarcinoma of the GE junction,
It is,
then the chances are more, both for liver metastasis and malignant ascites. So if you have to choose between the two in adenocarcinoma of the GE junction, yes, you must do an ultrasound. Squamous cell carcinoma, you may or may not. So you
yes,
can say that since it is a simple, non-invasive, inexpensive investigation, even if it doesn't give much information, I would like to do it because if it shows something, then it may avoid further investigations. So what does it
yes.
show?
So on ultrasound, liver is normal in size, but there's a well-defined hypoechoic rounded lesion, approximately 1.4 cross 1.6 centimeters in the right lobe of the liver of segment 5, likely to be liver metastasis.
Why is this not a simple cyst of the liver?
Um, it can be a simple cyst also,
What
sir.
is the characteristic feature of a simple cyst on ultrasound?
Sir, it is hypoechoic.
Hypo or something else?
Sir, actually, it is anechoic. I mean,
Anechoic.
yes, sir.
Anechoic. The
You,
characteristic appearance of a simple cyst will be anechoic. This is hypoechoic. So yes, the radiologist is right in saying that there is a suspicion that it could be a
yes,
metastasis. Although cyst also could appear hypoechoic, but characteristically it will be anechoic. Any other lesion which can typically be diagnosed almost with certainty on ultrasound as well in the liver? The sonologist can say, yes, it is this lesion. Can any lesion appear hyperechoic?
sir. Just on ultrasound or
Yes,
Doppler?
just on ultrasound. A hemangioma. Hemangioma is
Hemangioma, yes,
typically hyperechoic.
sir. Yes, sir.
Okay. Yes. Next.
Sir, this is a CT, sir.
So what CT you would have asked for?
Sir, I have done a neck, chest, and abdominal CT.
That's all. You will say CT, neck, chest, and abdomen.
IV, IV with IV contrast and oral contrast.
So you must, as I mentioned last time, you must say whether you just want a contrast enhanced CT, you want a CT angio, you want any specific protocol, how many phases you want, what contrast, IV, oral, rectal, oral, positive contrast, negative contrast, everything should be mentioned in the first go, complete description. Okay. Why not
Yes.
pelvis?
Um,
So in squamous cell carcinoma, usually neck, chest, and abdomen is good enough.
yes.
Whereas if it is adenocarcinoma of the GE junction, then you would include pelvis also, because you can have deposits in the pelvis, which are less likely with squamous cell carcinoma. Hmm.
So, so this is the plain film, sir. It this yeah. So the film shows esophagus, sir, with air fluid level, the contrast that we have given in the uh, um, oral contrast that we have given, and here we see the mass arising.
So there is a large intraluminal mass,
Intraluminal
which is
mass.
appearing as a filling defect in the dilated contrast-filled esophagus.
Yes, sir. And it extends below.
So first,
Uh,
you have to say where it starts. Upper limit is very important in esophagus. So you have to mention where did you notice it first.
Niranjan, why is the upper limit important?
Sir, we have to, sir, in case we are planning for, sir, I mean, in our management protocol also, if it is involving the cervical esophagus, we have to plan our treatment in definitive chemoradiotherapy form. And if it is, I mean, if it is way up, we have to give a margin also, 10 centimeter proximal margin we have to give to the patient. So the upper limit is important.
I mean, it's not that you have to give definitive chemoradiotherapy. There may be rare groups which may be even operating upon these patients, but operating upon a cervical esophagus usually involves laryngectomy and permanent tracheostomy also. That is why it is not done. But it is not that that is the only option. Most groups, yes, I agree, would give definitive chemoradiotherapy. Yeah. Show us where the mass starts. Little
Sir,
high.
the mass starts at the thoracic inlet, sir.
Almost at the little
Yeah.
lower down, because you are seeing good amount of lung here.
Yes, sir. And
So
then
thoracic inlet, you can see the manubrium. If you can see the manubrium, that the upper border of the manubrium, sternum, western eye will be.
Yes, sir.
Hmm.
It extends far below, sir. It is extending below. With still we can see some amount of oral contrast. Here we can see the tracheal bifurcation, and then again the lumen is visualized again with the oral contrast.
So when you see the contrast occupying the entire lumen of the esophagus, like here, whether round or oval, that is normal. Now go slightly up, and wherever you see contrast at a concentric place, like go slightly up here. So that means that there is still growth here. That is how
Yes,
you make out the lower. And the lower extent will be described in relation to the tracheal bifurcation, or if it is much lower down, in relation to the G junction.
yes, sir.
So the anatomical landmarks on CT would be the cricopharyngeus, the thoracic inlet, the tracheal bifurcation, the crus, and the G junction. That is how you describe the extent of a lesion.
Yes, sir.
So what
Uh,
else you would like to show us on CT of the chest?
Sir, on CT chest, sir, we cannot see any calcified or
No, first about the
lymph
growth
nodes
only.
or
So
any effusion in the lungs.
that is later. First, the growth. If it is in relation to the tracheal bifurcation, then you have to tell us whether the tracheobronchial tree is involved or not. You have to tell us whether the aorta is involved or not. You have to tell us whether the posterior mediastinum is involved or not. Then you come to the lungs and pleura. So
Yes, sir.
show the relationship to all these important structures.
So, sir, the tumor doesn't seem to involve the aorta, but I would like to comment over this better on the contrast phase. And
Okay.
uh, it also doesn't seem to involve the trachea anywhere, sir. Although there is abutment of the tumor towards the left bronchus, but I cannot say certainly on that there is involvement or infiltration of the left
But
bronchi.
go to the carina. Go to the carina. I mean, even here it is seen, although we will see it better in the. What is the normal shape of the carina? So there is indentation. What I'm
Yes,
trying
sir.
to tell.
Yes,
See,
sir.
the posterior wall of the carina has become concave, whereas normally it should be biconvex. So
Biconvex.
there is no infiltration, but there is indentation, which is because of the size of the mass. It's a large
Mass.
mass sitting
Yes,
right
sir.
at the carina. And if it is a in carinal or infracarinal lesion, which bronchus is more likely to be involved?
Left side, sir.
Left bronchus. So it is even an infracarinal lesion which is below the carina may be unresectable because of the left bronchial infiltration. So
Involved.
you have to carefully look at the left bronchus.
Yes, sir.
So any
Uh,
alteration of the shape of the trachea or carina or the bronchus also indicates suspicion of involvement.
yes, sir.
You should also mention the lung fields, whether they are involved
He,
with
he, he was
any
he was mentioning it.
infiltrates,
I
whether
interrupted
any
him. Yeah.
metastasis.
Yes.
Yes, sir.
Okay. Let's see the contrast film for better
Yes, sir.
delineation.
Just one more finding which I
Yes.
could
Yes.
find on the plain film. On the liver, sir, there were calcific uh, nodules which were seen.
Yeah. It's
So on
surprising that
segment
they were
5
not
on an
picked up
ultrasound.
on. It's
Yeah,
surprising that they were not picked up on ultrasound. They should have
ultrasound.
been
Yes,
very
sir.
well seen on ultrasound. Hmm. So what do you think these calcified lesions are?
Sir, because they are coarse calcifications, so these could be a sequelae of a old granuloma or old hydatid disease of the liver.
Even hemangiomas, I suppose, can get calcified.
Yes, sir.
Yeah. Let's see the contrast.
Yes, sir.
Demonstrate the metastasis in the liver.
On CT, did they find a metastasis or only these calcified lesions?
Sir, these calcified lesions only, sir. There were no metastases per se on CT. Sir, now again I can see the growth, and the growth extends below. Still, I have not seen any involvement of the aorta.
Yeah, but see the shape of the trachea.
Yes,
The
sir.
posterior wall is compressed
Yes, sir.
and it has become concave rather than convex.
Yes, sir.
Compare the shape of the right bronchus and left bronchus at that area. Again, the right bronchus is oval in shape with both borders being convex, whereas the left bronchus, the posterior wall is compressed.
Yes,
It
sir.
has
I can
become,
see one lymph node also. It is significant,
yes,
sir. Almost
yes.
around 1.2 centimeters, and it's round, so it could be likely metastatic. It could be a tumor deposit or an involved lymph node.
So large node with hypodense
Yes, sir.
center is very likely to be metastatic.
Yes, sir. Further, if I move ahead, anywhere I have not been able to see direct infiltration into the vertebra, aorta, or any bronchus, but there's still abutment of the tumor or a very close relation to the left bronchus, sir. The right bronchus appears to be free. There are no nodules in the lung. There are no nodules in the liver. The nodules which we are seeing in the contrast phase, I have compared them with the non-contrast phase, and those are the calcific deposits which we have previously seen. But there is no other metastatic deposit, no ascites also, which is noted in the CT.
So does the endoscopy finding correlate with the CT findings?
Uh, Sir, on endoscopy, they have given the lesion is far up, whereas on CT, it is slightly on the lower.
No.
Uh,
What was the level mentioned on endoscopy?
and endoscopy, they have given on reporting, they have given 10 centimeters, sir, but it is lower, sir.
Okay. And
Around 20 centimeters from the
which other
inside.
lymph nodes you should have commented upon?
Uh, sir, neck nodes, sir.
Yeah, squamous cell carcinoma tends to spread upwards.
Yes, sir.
Adenocarcinoma tends to spread downwards. So if you're dealing with a squamous cell carcinoma, you have to look at the neck nodes also. If you are having a adenocarcinoma of the GE junction, you have to look at the intraperitoneal nodes also.
Yes, sir.
Okay, let's see the CT report.
Sir, on CT chest, they have given a polypoidal mass of size 9 cross 3 cross 3 centimeters in the mid thoracic esophagus, causing dilatation as well as narrowing of the mid esophagus. The lesion is causing the elevation of the trachea as well as carina. They have suggested
Elevation
that
is not the correct term. It should be compression.
compression, yes, sir.
I mean, they are saying that it has got elevated anteriorly, and they haven't mentioned about the node.
No, sir, they have not mentioned about the node.
So what will you do now?
Uh, Sorry, sir.
No, please carry on.
Yes.
What will you do
Sir,
now?
now that I have done endoscopy and biopsy, sir, I would, sir, sir, I have to. It is a moderately differentiated squamous cell carcinoma. So I am thinking that in terms of neoadjuvant
Do you want to
chemoradiotherapy,
check the cardiorespiratory
so
function or
I will
not?
get a PET scan first, a
What about
baseline
this?
PET scan.
What about this tracheal elevation, which they have mentioned? And we also thought there is some compression.
Sir, we can do a bronchoscopy to rule out the clear-cut infiltration.
Do you expect any finding on bronchoscopy? And you should say tracheobronchoscopy.
Tracheobronchoscopy.
What do you expect to see in this case?
Sir, there can be direct infiltration and
This case,
ulceroproliferative.
in this case, you expect direct infiltration?
No, sir.
Yeah, the tracheal wall looked normal.
Normal.
There was no irregularity, there was no nodularity. So most likely what you will see is a bulge from behind,
Yes, sir.
which is compressing, or as they have said, elevating the posterior wall of the trachea or the left bronchus, and the mucosa is likely to be normal.
Yes,
This
sir.
is what you expect to see in this case. That
Yes,
is
sir.
why tracheobronchoscopy will not be of much help, because it will show the same thing what you are seeing on CT. What other investigation will be of help if you have everything on the earth? An endobronchial ultrasound.
Ultrasound. Yes, sir.
Just as you have endoscopic ultrasound in the esophagus, you can even do an endoscopic ultrasound, but problem is that this is a very large growth.
Yes, sir.
The esophageal ultrasound probe, which is even bigger than the upper GI, will not go. So an endobronchial ultrasound is a better investigation than tracheobronchoscopy. But at the same time, you can say that since you have a suspicion of involvement of the trachea or the bronchus, since there is a node which you think is likely to be positive, um, and you are planning a neoadjuvant treatment, then it becomes immaterial. Then you would
Yes.
prefer to look at it after you have given
Yes, sir.
neoadjuvant
Yes,
treatment,
sir.
isn't it? That
Yes,
would
sir.
be important if you are not planning to give neoadjuvant treatment. If you are planning a definitive surgery or upfront surgery, then it is very important to know whether trachea and bronchus are involved.
Yes, sir.
Okay.
Yes,
Yes.
sir.
So what was done in this case?
Sir, till now we have just we have just evaluated the patient, sir.
So they have said multiple calcified metastasis. Do you agree? Other
No, sir.
conditions, I agree, granuloma and hemangioma.
Yes, sir. Calcified metastasis, there will be stippled calcification, the coarse calcification which we have seen on CT, that is not very much going in sync with calcified metastasis
Yeah,
as the
I'm
diagnosis.
I'm not sure whether you can have calcified liver metastasis unless it's a very slow growing tumor and metastasis has been there for a long time.
Long time.
Like which tumor? In which tumor the metastasis in the liver may be even larger than the primary.
Neuroendocrine tumors, sir.
Yeah. So there are situations where you see multiple SOLs in the liver, large, bilateral, but there is no primary. Just whenever you have that situation, you should think, especially if the metastases are enhancing brightly in the arterial phase, you should think of neuroendocrine tumor. If you look carefully on endoscopy or on a DOTA scan, you will find a very small primary. So
Yes.
small primary, much larger secondaries is typical of a neuroendocrine tumor. Okay, what was done in this case? Go on.
Sir, we have just evaluated the patient, sir. We have to
Okay.
subject this patient for neoadjuvant treatment, and
What
then,
neoadjuvant treatment you will give?
sir, in our institution we give cross regime, sir.
What is that?
So we give 41.3 centigrade of radiation in 23 cycles, and we give cisplatin, um, cisplatin, platinum doublet, sir.
What is the doublet?
Sir, 5-fluorouracil and cisplatin we give.
Um, the typical cross regime included?
Pa- um,
Paclitaxel,
Paclitaxel and
if I'm not mistaken, there is paclitaxel. And do you give trastuzumab?
trastuzumab. No, sir. We don't we don't have HER2 receptor testing, sir. So
What do you
No,
mean you don't?
you should say that for that you need to do immunohistochemistry
chemistry, yes, sir.
for HER2 receptor, and if it is positive, then it will be of help, and that is more
Then
in which upper GI malignancy it is more important. HER2, it
in
has, in fact, in the Western world, it has almost become a routine to do HER2 testing. See a stomach.
Emma.
Now it is standard to do HER2 receptor testing.
Yes, sir.
You had some slides about the neoadjuvant treatment. We still have 5 minutes. You want to tell us about that?
Um, sir, the non-surgical treatment I have actually gone through.
Okay.
So I have certain chemotherapy regimes, sir, which can be done.
Yes.
Sir, so paclitaxel and carboplatin regime is used, and cisplatin and 5-fluorouracil regime is also used, sir. And there are many more. So for adenocarcinoma, we use ECF regime, sir, which is the MAGIC trial. I have a comparison in between the four RCTs. Like these were the initial RCTs which were carried out for gastroesophageal junction tumors, including squamous and adenocarcinoma both. And the results were comparison of chemotherapy group versus surgery alone group, and they found to be a improved overall survival and progression-free survival in chemotherapy group versus surgery alone. So that was the start. So this SWOG intergroup and MRC were the landmark for the starting trials, which was followed by MAGIC trial. This is for adenocarcinoma and squamous cell carcinoma both, sir, but lower esophagogastric junction tumors. And then there is cross regime, which was uh, perioperative chemoradiotherapy for esophageal or junctional cancers, and they give radiotherapy of 41.4, as I have mentioned, 23 fractions of 1.8 centigrade, and then 5 cycles of neoadjuvant therapy with reassessment and then followed by surgery, sir. So paclitaxel and carboplatin is given. So overall survival was again found to be better in chemoradiotherapy with surgery group versus surgery alone. We have a 5-year follow-up also for comparing the long-term results of cross regime. And again, we found that chemoradiotherapy followed by surgery group was much better than the surgery alone group.
Anything more recent?
Do you have to resect always?
Yes, sir. We have to resect always. Like, so there is a concept called as sanosurgery as needed in CA esophagus. So even if there is complete response, we have to go for surgery because um,
No, but at one stage you said that definitive chemoradiotherapy is an option. So
in cases of in cases where the patients are not fit for surgery, or if the disease has, I mean, the disease has not progressed or responded well, and the lesion is cervical esophagus, where the clearance is not possible. In those cases, I mean, the surgical morbidity
yeah,
of
but what
doing a
what what you have to understand and say is that the dose of radiation and duration of radiation is different. Here you are giving 40 or 45 gray in 4 or 5 weeks, whereas in definitive chemoradiotherapy, you have to give a much higher dose for a longer duration. It ranges from 60 to 70. So there, the intention is a definitive treatment. If the
yes,
patient fails, then you do what is known as a salvage surgery. Whereas here, even if there is a complete response, because the dose was not adequate, you have to operate. So
yes.
So this is a pure neoadjuvant. There is a difference between neoadjuvant and definitive. Definitive
Yes.
means that your intention is complete treatment. Only if
Yes.
it fails, you do surgery. Neoadjuvant, you have to operate.
Yes.
Okay, so students, if you want to read more about esophagus, send me a mail, vkkapoor.india@gmail.com. Write ESO in the subject of the mail. So I'll send you 2 chapters from my books, Clinical and Operative Surgery. I will also send you a review which was done by Dr. Murugappan with me on various regimes and protocols of neoadjuvant and adjuvant treatment in CA esophagus, which is a very useful read for all of you. So vkkapoor.india@gmail.com. Thank you, Niranjan. Thank you, Rajin, for joining. And Anand did join in the beginning. As I mentioned last time, Dr. Anand Nagar is currently in Korea on a 1-month fellowship, but he still tries to join and start the session whenever it is possible. Again, I would say all the students who are presenting cases, because we don't have time to discuss the operative surgery part in detail. If you want to follow it up by discussing the operative surgery of esophagus, indication, contraindication, preparation, technique, complications, send a message to Dr. Anand, request him for a slot. He will give you a slot, and then you can make a presentation about operative surgery part of CA esophagus. Okay?
Yes, sir.
Yeah, because in the exam, all of you are asked about one procedure. So I think that's also is an important part of JST, which we are missing. Very few operative surgery sessions have been presented. So whosoever is interested in making a presentation about operative surgery, please message Dr. Anand. Okay,
Yes.
we will close. Thank
Yes,
you.
sir.
Thank you
Thank
very
you, sir.
much.
Thank you, sir.